Hello and good morning, everybody. We are so excited to welcome you to our webinar this morning. We are waiting for a couple more attendees to join the call, so please just bear with us as we wait for a few more people to be on the line, and we'll get started shortly. So feel free to grab a cup of coffee or just have your microphone or your questions ready to go. Also, if you're feeling friendly, you can add in the chat your name, your organization, maybe where you live. Just say a quick hello. I'll start it off in the chat if anybody else wants to add on. It's great to see these names in the chat. If you're just logging on, we just want to say good morning, good afternoon, good evening, wherever it is for you. Just pop a quick hello in the chat, say your name, where you're joining from. And yeah, it's great to see all of these names in the participant list and also some interaction in the chat. We'll be starting shortly. We are just waiting for a few more attendees to join the call. It's great to see we have different regions on the line. Hello from Tanzania, South Africa, Russia, Senegal, Kenya. It's great to see everyone on the line. We're going to get started shortly, but like to see all of the different names popping up. Well, in the coming hour, we'll have time for Q&A. So hopefully we'll be able to, interact with a few more of you. All right. Well, I think we have enough participants on the line and people will continue to trickle in throughout the call, but we'll get started just in the interest of time. So welcome everybody and thank you for joining us. My name is Yassine Bai and I am an associate on the data and performance management team at FB 2030. And it is my pleasure to moderate this webinar on transforming health systems to respond to the needs of adolescents. So the next slide is the agenda for the call. We'll have about an hour for the full webinar with 15-minute presentations from our presenters. And of course, we'll leave time at the end for questions from the audience. And on the next slide, you'll see our meeting objectives. So we'll first hear from Valentina Baltag from the World Health Organization on best practices and lessons learned that can stimulate new thinking among youth-led organizations on how to improve data collection. And next, we'll hear from Kamani Karuga from USAID's Momentum, Country, and Global Leadership, and they will discuss the processes to strengthen the adolescent responsiveness of county health systems in Kenya. And finally, we'll have a discussion with both speakers on recommendations on how governments, partners, and youth can support the use of data to improve system responsiveness. So before we get into these great presentations, I'm just going to quickly review some key logistics for the webinar. So first, in addition to today's presentation, you will see a Q&A pod at the bottom of your screen where you can submit questions. So please feel free to add questions anytime during the presentations, and we will get to them during the Q&A portion of the call. Speakers will be sharing their videos during this call. So as they are presenting, if you'd like to view the presentation slides and the speaker videos, just be sure to look at the video panel on the right-hand side of your screen. You can select the viewing options on the top to see the speakers in your preferred view. And finally, if you experience any technical difficulties, please use the chat box so you can send chats to all attendees or to meeting hosts. We have a few logistics team members on the line that can quickly support with any logistical issues. So with that, I'd like to turn it over to our first speaker, Valentina Baltak from the WHO. So Valentina, the floor is yours.
Thank you very much. Just to confirm that you can hear me.
Loud and clear. Thank you.
Thank you. So I'm so very pleased to present in this webinar what is the response to make health systems adolescents responsive. I will cover in this presentation what are adolescent responsive health systems. It is important that we all have the same understanding. And I will present the key actions towards adolescent responsive health systems and universal health coverage as they are presented in our guidance. I will also use the opportunity of this webinar to feature the latest guidance from WHO that can help you, your organizations, and your countries in making progress towards adolescent responsive health systems. Next slide, please. So what are adolescent responsive health systems? Next slide, please. It is useful to remind the WHO health systems framework that was developed with this very end to promote a common understanding of what a health system is and what constitutes health system strengthening, because different people might mean different people, and common understanding is very important. Central to this framework are the 6 building blocks of the health system. The building blocks are on the left-hand side of your screen. It is service delivery, it is health workforce, health information systems, access to essential medicine, supplies and technology, health financing, and leadership and governance. But those blocks, or sometimes they are referred to as key functions of the health systems, they do not exist for their own sake. We do not deliver services just to deliver services. We have in mind some ultimate goals, and those are in the right-hand side of your screen. So those goals is improved health, as measured by, for example, reduced mortality or morbidity, improved fertility rates. An important goal is also health systems responsiveness, how it does respond to the user needs. It is also about social and financial risk protection. So people use health services without incurring catastrophic expenditures. And it is also about improved efficiency. You can deliver services and achieve certain outcomes at a very high cost, but there is an opportunity cost how we use our finances. Therefore, improved efficiency is an important outcome. Now, in between those two are the intermediate outcomes, such as access, coverage, quality, and safety. And here is where patient engagement and community engagement comes into the equation and into this framework. Because without patient engaging properly with, for example, just to give one example, the advice given by the healthcare provider, then the outcomes will not be achieved. And research has identified that since we did have this common understanding and articulation of what health system strengthening means, then it was instrumental to progress in countries, and it was really a catalyst. Now, from this, what are then adolescent responsive health systems? Next slide, please. Adolescent responsive health systems then is nothing else that making every function or every block of the health systems tuned to the specific developmental needs of adolescents. It means, for example, that service delivery should be the platform or how you reach adolescents should be tuned to where adolescents are. Just to give one example, or the health workforce, an adolescent competent workforce means that the workforce is trained in the developmental needs of adolescents. And what is different when you have a client adolescents vis-a-vis when you have a child or an adult. So adolescent responsive health systems is including all the same building blocks and all the same outcomes, but with adolescent specific considerations. Sometimes very often we are asked what is the difference between adolescent responsive health systems and universal health coverage. You see that, and you remember perhaps the definition of universal health coverage, which is providing all people with access to needed health services of sufficient quality without exposing users to the financial hardship. So universal health coverage is the end, whereas the adolescent responsive health systems is the mean. So universal health coverage is in this middle part of the graph, which is about access and coverage. So it's an intermediate outcomes before you improve the health and equity and financial protection. Next slide, please. Now, in details, what are the key actions to achieve adolescent responsive health systems? I will refer you to the AHA guidance. So the guidance is accelerated action for the health of adolescents. Here I will just give some highlights. The adolescent responsive health systems are described in the AHA guidance alongside those building blocks: leadership, protective laws and policies, adolescent responsive financing, service delivery platforms, competent providers, health management and information systems, as well as adolescent leadership and participation in programming for health and well-being. Next slide, please. So some details and highlights for each of those building blocks. To have a leadership for adolescents within the Ministry of Health and across the government means to have a national level mechanism to oversee and coordinate efforts for adolescent health and well-being across sectors and government ministries. Specifically for the Ministry of Health, it means to have an adolescent health focal point in the Ministry of Health. And we don't mean here somebody who is dealing with maternal and newborn health, for example, that inter alia is also dealing with adolescent health. No, we mean a focal person that is dealing with adolescent health in a holistic way across many health issues. And then leadership, it also means that to have national and sub-national, for example, district level political and administrative capacity and leadership for adolescent health. Next slide, please. Adolescent protective laws and policies. We highlight in the AHA guidance the key laws and policies that are pertinent and needs to be reviewed if necessary for adolescent health. And I will mention two here. For example, the protection of confidentiality. It means, for example, to have standard operating procedures when confidentiality may be breached. And also to remove in the normative framework of the countries the barriers for minor adolescents to consent and assent to services. Next slide, please. Adolescent responsive financing means attention to three aspects of financing. who is covered, for how many services, and for how much of the costs. And in the figure here, some of you might recognize what we call the financing cube. So you see the big cube and the green one inside the big cube. So the big cube is the ideal situation when everybody in the country, for our webinar, it means every adolescent is covered for any services they want, massages included, for example, and they do not pay anything for those services. Now, this is a situation that no country has and no country can ever have. The challenge is that from where you are today to make progress towards universal health coverage. So one would have to see who is covered, which adolescents are currently covered, for example, by basic benefit packages. Only younger adolescents, then you will expand the coverage to older adolescents. Then for how many services? Is it only sexual and reproductive health or only mental health? Then you will have to make the next move and to cover more services that are key for adolescents. And then for how much of the costs? Are 100% of the costs covered or only part of them? Then the progress will be from where you are today. Next slide, please. So in terms of the actions, it means actions related to generating financial resources. For example, making a good investment case for your government about the importance of investing in adolescent health. It is also articulating very well what is the national package of adolescent health intervention and services that you want to be covered, but also to have this national package guiding purchasing decisions, not only be a document on the shelf on the adolescent health focal point office. And then on the side of financial risk protection, one would have to think what are the ways to maximize the number of adolescents covered by an effective pooling arrangement, and also to reduce or better remove out-of-pocket payments at the point of use, which we know are an important barriers for adolescents to use services. Next slide, please. For adolescent competent workforce, it means to define the core competencies in adolescent health and development and put in place competency-based programs to train professionals. And the details and what are the core competencies are in this document that was published in 2015. Next slide, please. Similarly, for service delivery platform that maximize coverage and promote equity, we have the global document, which is the national standards and monitoring for quality healthcare services for adolescents. So the actions will be that a country will have to define national standards. This global document might serve as a guidance, but articulating what are the national standards, and those will be based on where the key problems with the quality in the country are, and then implementing the standards, and importantly monitoring them and setting in motion those cycles of quality improvement. In terms of maximizing coverage, we recommend to pay very close attention in investing in school health, including school health services and telehealth, because those are the modalities with a great potential to reach the majority of adolescents. Next slide, please. And adolescent mindful health management and information systems means having systems from the facility level all the way to the district and national level that collect but also report age and sex disaggregated data on adolescents. It is also important to collect data on health determinant and behaviors related to the health and well-being. And there are standardized surveys that exist, so we encourage countries to apply those surveys on a regular basis and use the results as a basis for decision making. Next slide, please. And adolescent leadership and participation. Again, key actions are in the AHA guidance, but we do recommend that there should be structure and processes not only to institutionalize adolescent participation, but to create forums for their meaningful engagement at all levels, not only national, but also subnational and importantly, local level, and also set minimum standards for participation, so to ensure equity of participation, and to invest in adolescent capacity for participation. That means legal awareness and literacy, competencies to play an effective role in governance and in accountability processes. Next slide, please. So last minute to feature very briefly the latest guidance from WHO, but I believe slides will be made available to participants in this webinar, and you will have the opportunity to retrieve them on WHO website and see in details what is their content and how it can help you. Next slide, please. So last year in 2021, we have published this tool, which is assessing and supporting adolescent capacity for autonomous decision-making in healthcare settings. This speaks to the AHA recommendation of removing barriers for assent and consent for adolescents to services. So I will leave you to study how this can help you. We also published last year the guide how to plan and conduct telehealth consultations with children and adolescents and their families. That will help you. The title is self-explanatory. And also for the part of the strengthening service delivery platforms for adolescent health care, we have published last year the first ever guideline on school health services. On the advocacy side, in the middle of this slide, you see the cover of the document, which is called Adolescent Health, the Missing Population in Universal Health Coverage. This will help you to make a case for UHC for adolescents in your country. Next slide, please. The guidance on making every school a health promoting school was published in summer last year, and we are supporting countries to strengthening their school health program, which is an important part of the AHA agenda. Next slide, please. And we also work in helping the global community and countries to articulate what are the core indicators for the measurement of adolescent health and well-being. Several papers are published, and we will publish soon the list of 30 core indicators that are recommended, which are now being field tested in a couple of countries. Next slide, please. With this, I want to thank you for your attention and looking forward for your question and for further interaction. Over to you, Yasin.
Thank you so much, Valentina, for this wonderful presentation. Like she said, if there are any questions, please add them to the Q&A pod and we'll be sure to address them during the Q&A session. So without further ado, I do want to turn it over to our next presenter. So Kamani Karuga from USAID's Momentum Country and Global Leadership. Kamani, the floor is yours.
Okay, thank you so much, Yasin. I hope you can be able to hear me.
Yep, all sounds great. Thank you.
Okay, perfect. So my name is Kamani Karuga, and I'll be presenting on behalf of Momentum Country and Global Leadership. And my presentation is going to build on what Dr. Valentina has talked about, but further provide you with some of our field experiences of assessing how adolescent and gender responsive the health system is in a context of a subnational level in Kenya. So next slide. So we start off with a general consensus, a general agreement that it's important that health systems are adolescent responsive. In fact, in our assessment, we added gender as part and parcel of that responsiveness. But then agreeing that there seemed to be very limited exploration or very limited information out there in terms of how you can operationalize this concept, especially and particularly at a subnational level, whether that be a county level or a district level. So in response to that gap, ASEC Momentum developed a tool, an adolescent and gender responsive assessment tool that we applied in Kenya leveraging on a project that's funded by USAID. And we focused on these two counties, and just for your information, the two of them are counties that are considered to be low performing in terms of general health indicators, but also historically marginalized. So you'd expect the health system there is already performing quite poorly. Next. So I'll start off by just giving you a little more detail about the tool. And the tool was developed by Momentum, but had inputs from a wide spectrum of experts and stakeholders, some of you who are in this call. And the tool is aimed to help stakeholders, including those in the ministries of health, but also partners, to reassess how the health responds to the needs and rights of adolescents. And this goes from the very basic level of acknowledging that adolescents face age-related barriers, gender-related barriers as well, but there are opportunities out there that could be applied to really make it better for adolescents, particularly in terms of the quality of care that they see. So the tool was developed to be used both at a national, but as well as sub-national level, and to assess the existing situation in terms of plans, in terms of programs, in terms of budget allocation, resource allocation, as well in terms of existing policies. And it was also developed to be able to inform the design and implementation of programs, both by government, but also by non-state actors. But the tool as well can be used to measure and monitor the progress of the health system in terms of its ability to meet the needs and rights of adolescents, and especially if applied at the beginning and at a later stage, such that you can be able to compare how the system is scored at the beginning and then at a later stage. Next slide. So here, I'll try to describe the tool for you, but as well, you can access it if you like. We can be able to share this. But this is how it looks like. As Valentina explained, we focused on the WHO health building blocks. I really added the community because we think community could be looked as an additional building block that is integral. But for each of the building blocks, the exercise started by asking ourselves, what are the key features that would make this block to be considered responsive to adolescents and gender? Then after coming up with those features or attributes, as you like, then the next stage was developing some kind of a rubric that could be used to score that feature. So we came up with a rubric that had 4 levels, 0, 1, 2, and 4. Kind of incremental, starting with 0, which would be really the very basic, to 3, which would be the most advanced level for that feature. Then there you see there is a column where we write the score, but as well the notes for the assessor, just basically the observations that are made. Then the tool is available as well in Excel that is linked to a dashboard and a visual presentation of the assessment results for ease of quick interpretation. Next. So now this slide describes the process that we used in Kenya in the 2 counties that I mentioned of Turkana and Samburu. We considered it very important to start off with the views or gathering the views of adolescents themselves. So we had focus group discussions with adolescents, segmented by sex. We had a group or groups that represented girls or female adolescents, and others that represented male adolescents. And we had a tool that we ran through, basically again organized through a similar framework, really gathering their views on what they thought or their own perception of how the health system addressed their needs or met their rights. Then after that, we had a working session or a working workshop with the provider side. And this was a group constituted of the managers at the county level and also the lower levels, including health facility managers, but also implementing partners, including CSOs, and other relevant government departments or line ministries, including the Department of Youth and Gender. We also had youth represented in that workshop. So during the workshop, there were discussions and really reflective discussions, really looking at each of the building block and each and every feature at, at a time, and getting down to really unpacking how the status is and how well it met the needs of the of youth and adolescents. And there was a process of triangulation, and here is where we try to compare or try to harmonize the views of the providers vis-a-vis the youth's view, or the views and perceptions from the youths themselves, including the results from the FGD being presented there. We also explore documentary evidence to be able to come up with a consensus, and then based on that, we allocated the agreed upon score for each of the features. Then all that was gathered in a visual representation of the scores for each of the blocks and features. And that helped to really come down to what the participants thought were the priority gaps that needed to be addressed. And they went ahead to then produce an action plan that addresses those gaps. Next. On this slide gives you a view of how the visual representation of the scores look like. The spider web diagram basically looks at the aggregate scores per building block. For this instance, in one of the counties, you can see that, for instance, health workforce as a block performed quite dismal as compared to health information, for instance. And then on the right, you have the blocks and the features and the scores color-coded to be able to track the assessor's attention to the areas that are performing poorly, the ones appearing as red. Next. So for the two counties, here are the key gaps that were identified through this process. And this basically presenting what came out as cutting across both counties. One is limited adolescent participation in planning, in policy making, and as well in accountability mechanisms. You would find, for instance, if there are health facility committees, adolescents were not represented in there. If there are, for instance, community health committees, again, adolescents not being represented. Then the other gap that came out was poor translation of policies and guidelines into quality service provision. And part of this was also because these guidelines and policy documents were not widely disseminated, especially the lower you go to the facility or to the levels that are supposed to implement those guidelines. Then the other thing that was noted is the fact that adolescent and young people health services were highly fragmented, very poorly coordinated, and generally of suboptimal quality. We noted that routine supervision, when it happened, did not consider the aspects of adolescent and gender. QI processes, QI tools were quite silent on adolescents. Then the other thing we also noted was that most providers and managers had inadequate adolescent competencies. Dr. Valentina mentioned about the WHO adolescent competencies, and we did realize that were not well known at that level. There are also gaps on data in terms of availability of data focusing on adolescents. Age disaggregated data was not generally available, but much more concerning was issues of data privacy. In certain instances, we were told that the adolescents were keeping off from services because they thought their records were not held in confidentiality. Then the other element was on community-based interventions. Much of the existing community-based interventions were targeting maternal, newborn, and child health services, and were quite lacking in terms of adolescent focus. We did realize there were some initiatives that were quite working in silos, focusing on adolescent, but quite a number of others that were focusing on livelihoods and economic development, but really not integrated or lacking in linkages between them. Next. So these were the actions that the two counties prioritized and committed to ensuring that they went into their work plans and budgets. First one was that they were to ensure adolescents are part and parcel of public participation forums, especially during planning and budgeting. And they were to be included in management of health facilities and as well in the existing social accountability mechanisms, especially those that were being supported through other programs. We also agreed that there is need to have to do better in terms of dissemination of national policies and guidelines on adolescents. And this was to happen at the lower level, particularly because it so seemed that documents trickled up to the county level. And now I went lower to the facility, to sub-county and also facility levels. Then there was an urgent need to improve provider competencies around adolescent health through training, both pre-service and also in-service training, and to also think about improving quality improvement supervision, incorporating elements of adolescent health. And the other element was in terms of improving HMIS data, ensuring that disaggregation is happening to capture all the subgroups of adolescents and young people, but more importantly, ensuring that data privacy and confidentiality is considered across all levels. Then lastly, they also agreed to adopting tailored and multiple service delivery strategies, ensuring that adolescents are included in all service delivery points, including community and outreach services, but also ensuring there is linkages and integration with programs, particularly that address determinants of adolescent health, including economic support. Next. So as I almost conclude then, here are the reflections that we came back with from Turkana and Samburu. In terms of findings, we did find that both counties have multiple areas that need attention to make the health systems at our level much more adolescent and gender responsive. There are opportunities, a lot of them, that the counties could really leverage on. In terms of the process and the tool that we used, participants themselves, we did ask for user appraisal of the tool they process. And as you can see, the majority of them found the assessment process helpful, and they did agree that they could recommend that to others. And I think one of the most important findings or that came from that exercise was the fact that the county health system leadership themselves noted the importance of shifting the thinking from what has been the approach of providing health and youth service through youth corners to a much more systems-oriented approach, where adolescent youth and gender considerations are embedded across every aspects of the health system, like from planning, budgeting, allocating resources, and also delivering services. Then it was also noted that whenever you want to do an assessment of the nature, very important to ensure that the views of adolescents themselves are considered, and both both male and female adolescents, ensuring that they become part and parcel of the dialogue, and that will then include their own issues from their own perspectives into the planning table, and avoid scenarios that we have seen where their needs are really at the periphery. And we did also realize that this tool present a huge opportunity for monitoring progress, especially because of the scoring and the participatory process of scoring, which can be done at the beginning and redone a year or so later, or whatever at the end of a program or intervention. That way you'll be able to compare the scores at the beginning and later. And that forms the basis for a discussion on how progress is being made. Next. So I thank you, and I really look forward to engaging you in a discussion of more of those experiences. I hand you back to Yasin.
Wonderful. Thank you so much, Kamani, for the presentation. And to both of our presenters, I know there's been a few questions coming in the chat, so we'll turn to the Q&A. But before we do, I just want to quickly highlight the work of the FB 2030 Adolescent and Youth team. So Emily Sullivan, who's FP 2030 Senior Manager for Adolescent and Youth Engagement, is working with 5 youth-led organizations to change the way we talk about and implement equitable partnerships between youth-led organizations, donors, and INGOs. So this initiative is driven by the need to end systemic inequities and systemic inequities that currently thrive within relationships between youth-led and youth-forced donors and NGOs. So I'll put the link in the chat so you can take a look and learn a little bit more about the We Trust Youth initiative. And now I want to turn over to the rest of our Q&A session. So thank you all for sending in your questions. Maybe I can just answer probably the most popular question is that we will share the presentation and the recording after this webinar. You'll see an email from FP 2030 in the coming weeks with that. So to start off the Q&A, I'm just going to toggle through and figure out the questions. I know a few of them were answered live, but maybe we can start with a question for Valentina. Oh, and apologies, before I do start off, I do want to introduce another speaker that will be participating in the Q&A, which is Callie Simon. She's a youth advisor for Momentum County Country and Global Leadership. So thank you so much, Callie, for supporting the Q&A. And we'll have all of the speakers up on the screen and they'll answer questions as they're directed toward them. So back to our first question for Valentina are there global standards for youth participation? Valentina, please feel free to unmute yourself and turn on your video so that we can have your answer shared with everyone.
Thank you. So there are no global standards for youth participation published by WHO, like WHO standards for youth participation, but many agencies have published standards and recommendations for youth participation, and I have put some of the examples in the chat. We also have in the AHA facilitator manual, for example, the example from Girls Not Brides materials, those are really frame the standards for youth participation. And the standards usually, what do we mean by standards for youth participation? The key issue is how to ensure that youth participation does not increase inequalities, and that two key issues. There are several others, but the key in my mind are those. One, that those who are delegated to represent youth are chosen in an explicit and equitable manner. Not only those that are better off have access to such platforms and participations. And the second is that they really represent youth. So it's not, a relative of high-level official that had the chance to be nominated, but that behind this delegate are really youth-led, youth-serving organizations or wider youth communities, and that this person has a mandate to represent them. So that's to point just of the key considerations in youth participation. Then another consideration is to have representations at all levels of decision making. We have made progress lately in recent years in youth participation, but this progress, I might be biased from what I see, but my bias is that those mechanisms have been set mostly at the national level. For example, countries that went through the process of analyzing the situation of adolescents and developing national adolescent health strategies for the last 5 years since the AHA guidance was published, they all dutifully adhere to the principle that youth should be engaged in this process of strategy development, and mechanisms were created or used existing mechanisms. I don't want to say that, with the AHA this started, were created at national level. But this does not yet happen at local level. And when we mean local level, really think about a small community which has a primary care facility, nurse-led facility, for example, with a team of community health workers, and then that adolescents in this community or young people in this community participate in some ways of informing what services they need and also giving feedback to the facility. So that's just two extreme examples of youth participation. So I think this does not yet happen as a routine, and also the district level, obviously. Over and maybe just to one more recent material on youth advocating for change for adolescents. So this is the second document in the chat that I have put. It is relatively recent, and those of you who do not know this document, please do use it. It was an interagency effort to develop it, led by the Partnership for Maternal, Newborn, Child, Adolescent Health and Aging, and it's very practical resource for youth-led and youth-serving organizations. Over.
Great, thank you, Valentina. I appreciate that answer, and I think we'll be able to share resources afterwards. I do want to welcome Callie. I know you in the chat, you've mentioned how the work that Kamani presented on is reflected in the work that Valentina and the WHO work on. Do you want to say a quick word on that?
Oh, sure, I can. I was actually going to add something to the previous comment. Hi, everybody. My name is Callie Simon. I'm happy to be here with you all. I was going to mention that in addition to the resources Valentina shared on, adolescent engagement and partnership, there's a recent high impact practices strategic planning guide that was just released last week, I believe, that outlines some step-by-step processes that colleagues who are interested in really meaningfully engaging and partnering with youth can take. It was developed in partnership with youth-led organizations and young people themselves, and it's meant to support operationalization of that global consensus statement that Valentina mentioned. So I'm just going to pop that in the chat box as well, and I wanted to call attention to that kind of step-by-step resource for additional guidance on that topic. And then I can comment, sure, on the previous question you asked, Yassine. And I don't know if there's more to say actually than what I put in the chat, which was just that the work that Kimani presented on, and Kimani, you can turn your video on if you want to chat with us, presented on directly, the responsive systems tool directly corresponds to what Valentina laid out in her presentation. So I wanted folks to know that these two things are very closely linked. The kind of features and standards for each of the building blocks that Valentina walked through is what the tool that we've developed seeks to allow governments and county and sub-county and subnational stakeholders to assess. So these are linked, not separate parallel endeavors. One is meant to kind of help operationalize and assess the degree to which the description, the features that Valentina described are present or not, and allow prioritization of where we should take actions.
Thank you, Callie, for clarifying. And Valentina, please go ahead.
Yes, and just to complement Callie, I think it's important that participants in this webinar and the future users of this tool understand that they are very much interlinked. So it's not another tool, is making it easy, kind of a desk type of review assessment of the health systems. And it might be part of what we call in the AHA, needs a situation analysis, because in the AHA process, when a country starts or retakes the process of thinking about adolescent health, for example, revising a strategy that exists or developing a new one. So the first step is to do the situation analysis, landscape analysis, and then prioritization. What will be the priority that the nation wants to focus in the next 5 years? So this tool that will be released after the field test in Kenya can be part of the situation analysis. So it's another tool to be used in the context of interactive workshop, but also outside of the workshop, because some of the information is gathered in different ways. Over.
Thank you both for that quick interaction, and also appreciate all the resources in the chat. We'll be able to share all of these after the webinar so we can take a deeper look. But I do have another question from an audience member, and I think this can be for any panelists, but the question is in reference to the point on poor translation of policies and guidelines into service provision. So how can we move beyond just developing tools to putting them into practice? And also, what is needed and how can young people be more involved in accountability? Valentina, I know you're unmuted, so maybe you can just start off.
Yes, thank you. It is very important question, and I do not believe that you can set a different mechanism for accountability for adolescent responsive health systems than the one that exists. And let me just take two examples, one regarding the quality of care and the second one regarding the provider's competencies. So in every country now, or in almost every country, there are mechanisms that are overseeing the quality of healthcare and healthcare services. And it is an unrealistic expectation, and not only it is unrealistic, it's unnecessary that we set up something parallel for quality improvement. I would say for quality monitoring and assurance. And it means that those mechanisms that exist in countries, the adolescent health community, or those who advocate for adolescent health, and then the decision makers who were convinced that, yes, okay, you know, we made the case, we are convinced it is important, then they reflect, okay, what are the current mechanisms? Who is the institution in the country, who is, or the institute, the national branch of the government or arm length institution that is responsible for the quality of care? How do we work with them? What are the tools they are using to assess the quality? So you will have to go under the skin of those tools and processes to make sure that if they once in 5 years or once in 2 years conduct a quality assessment survey, a nationwide exercise, then the elements of quality that is specific for adolescents are captured. And then you'll have to decide what are those essential elements. So this is one example. Another example might be there is a process of accreditation of healthcare facilities. I do believe, you know, it's more how well it is developed is different in different countries. One would have to see how these processes can be used, maybe not for every facility, but at least facilities who have a certain threshold of adolescent populations, of adolescent clients. Say, I don't know, 20% of the clients of this facility are adolescents. Then this facility should also be accredited against how some elements of quality assurance. For example, does it ever ask adolescents about what do they think, like exit interview? If this facility never does exit interviews or some types of opinion from adolescents, how they can serve 1/5 of their population? So those are just a few examples that it needs to be embedded into the existing mechanism. But the first step is you have to convince the policymakers that this is a needed investment. So this goes back to making an investment case, gathering your data, you know, articulating the triple benefit, the triple dividend argument for your country, that investing in adolescents today in a country that has up to 30% of the population in the age range of adolescents and young people, then you know, the gain today, but it's also the gain tomorrow, and for the next generation. Over.
And Yasiri, if I may jump in there to really agree with Dr. Valentin that this, I think the question boils down to resources. And given that we are in a setting of scarce resources, you know, there is a priority setting that has to be within that context. And that calls for evidence, and there has to be an evidence base for which planning and resource allocation is being done. And the lack of data that speaks to the need of adolescent or this cohort then becomes the first hurdle that you face. You know, their needs tend to be invisible because they are not really highlighted in data. So if we could be supporting countries more to really ensure that we are gathering more data on adolescent health, the state of their uptake to services, and the challenges they are facing accessing those services, that would be a good starting point. And then it opens the conversation on where the resources will come from. For the case of Turkana and Saburu, where we did our assessment, after the priority setting exercise, they came up with an action plan. The big question in the room was then, how we have agreed these are the immediate actions that we need to take. They need resources. Where will those resources come from? And a very interesting conversation ensued, because then we were asked the county government or the government at that level is how much of these resources do you already have? How much of these actions actually require very minimal resources rather than a shift in the mindset? How much of the existing programs can we leverage, really try to, leverage on existing resources, opportunities to improve on what programs we're already doing. And what we came up with as an action plan, it would be interesting to go back there. We are planning to go back there in a couple of months to reassess the progress they have done against their own action plan. So the point I've tried to make is that the conversation really opened the doors to really reflecting and bringing to the top of the agenda issues of adolescents.
Thank you both. And, we'd love to find ways to stay updated on the programs and such. So please do feel free to share, how everyone on this webinar can follow up. Kamani, my next question is actually for you, specifically on your presentation. So what type of actions did counties take in response to the assessments?
So good question. So the process of coming up with the action plan was where, we looked at how the health system scored and decided the areas where they scored are red, the worst performing areas, kind of then took a back step and said, what can we be able to do in the immediate term? What can be done in a more medium to longer term? And the team then came up with the prior actions that they want to take. And as I was saying, the next thing was to decide how to integrate those actions within their annual work plans and budgets, and within their day-to-day activities that were already happening. So examples, for instance, of actions that were thought to not require a lot of resources, basically a shift in the way things are done. But for instance, including adolescents in management committees of health facilities or community health committees, including them in the existing community accountability mechanisms. So those were things that the distribution, for instance, of available guidelines and materials, including policies. Those were things that the participants or the county folks agreed that they could quickly be able to do with very minimal support. But then there were other actions, particularly as it relates to service delivery, that required much better, much more intensive planning. For instance, looking at how services were delivered, looking at service delivery points, how responsive they were to adolescents, looking at service hours, for instance, the training providers to make them much more responsive to the needs of adolescents. So, and other actions, for instance, in terms of data and data systems and tools, and ensuring those are available and data is being collected and analyzed and used in the actual planning. So, I wouldn't say that I can comment on the extent to which those actions have been implemented since then. As I did mention, we will go back there in a couple of months' time to assess how well they have progressed with those. To be an interesting thing to find, and we will repeat the same scoring, same process. And produce perhaps an overlay of that spider diagram, and that could be at a snapshot. You can be able to see which of the building block has shifted from what it was to a better position, perhaps.
And if I just may add on the next steps that Kimani laid out, where Momentum Country and Global Leadership over the next course of a year is going to be not only supporting the counties in these kind of repeat assessments to see progress made, but in documenting the processes, the challenges, the barriers. So I saw a question from Amy, and I know Valentina will likely respond, but we are through this work at the sub-county level, or sorry, at the county level, planning to really try to understand the processes of operationalizing adolescent responsive systems and services so that we can better identify identify barriers and ways to address those barriers that can then be hopefully used by others working in other contexts. So that implementation learning process is kicking off now and should go over the next year. We'll be happy to share those processes and that learning with you all as we gather it.
Wonderful. Thank you both. And thank you, Kelly, for that add-on. So I know a couple of the questions have been answered live. So I want to turn it to one of our last questions. And this is actually for all panelists. Can you please just share your insights or recommendations that you have to prepare adolescents to participate in the assessment, analysis, and workshops to ensure equitable partnerships with government, recognizing this the power dynamics? So maybe we'll start off with Valentina.
Thank you. In the course of applying the AHA guidance in countries, as I said, every country to a different extent, but every country did involve adolescents in those AHA orientation and capacity building workshops and national prioritization workshops. So those experiences are documented in the AHA facilitator manual or AHA manual to develop national adolescent health strategies and plans. So this is the manual that describes how the experiences of countries, how to set up this, what happens in a country that wants to use the AHA guidance to develop or update national strategies and plans. So it was published a year after the main AHA document. And I want to point your attention to the case studies in this guidance. So there are a few case studies that document those experiences with a particular focus how youth were involved. And this is the case study from Belize. It's a case study from Sudan, a case study from Barbados. The key, what is common in those case studies, that prior the AHA orientation and capacity building and prioritization workshops, it's a series of workshops, youth were capacitated, trained, introduced into the guidance and into the essence of what is situation analysis, what types of data, needs assessment, landscape analysis. So they came to the workshop already prepared and familiarized with the key concept, but also with their idea ready. So this is building their capacity prior the actual event is very important. But then again, how they were selected and how they were engaged, what were their particular inputs, is described in those case studies. I think another common feature was that they really participate for some sessions and for some questions. They worked, discussed separately in the youth group, but for many, if not most of the sessions and type of inputs, they were part of the other groups. So it wasn't like youth working separately, thinking about AHA, and then the other policymakers were making their recommendation. So that's one learning. And when the time comes, I would like also to answer Ami question, which is the next one in the chat.
Great, thank you. Callie or Kamani, do you have anything to add on to this question?
Yeah, I think just to say that for us, the focus group discussion was, from my own reflection, was a really great moment in terms of hearing feedback from adolescents about what they think, their perception about the way services were delivered, the way they access those services. We had very interesting feedback, for instance, regarding the way health workers treated them, some judgmental attitudes that were keeping them away from services, for instance, to hours that services were available, not really being conducive to adolescents that were not available during those hours. So, and facilities not being available during the non-traditional working hours. We had feedback regarding, for instance, where the condom dispenser was placed vis-a-vis, the waiting bay, for instance, and all that. So there were great feedback that came from the adolescents themselves, and more opportunities need to be created for that kind of feedback to come through. So I would welcome, for instance, suggestions that were given by Dr. Valentina about, kind of institutionalizing exit surveys as part and parcel of routine feedback from the users of services, in this case, the adolescents. So those are just suggestions, hints, and ideas of how we can get better.
Thank you both. And just to quickly touch on that last question that we had in the chat. So for Valentina on the AHA framework, just to share the common experiences and challenges that government and subnational entities have in creating adolescent responsive health systems, and what are the greatest barriers to country successes? Specifically, how can the donor community better support these common challenges in project-oriented funding cycles?
Thank you. So great question. And I want to highlight three issues here at stake, which some of them also, for the attention of donor community, but also for the wider audience. The first one is the importance of having adolescent health focal point in the Ministry of Health, and also a platform across the government. And this is very often not yet the case, although our regional colleagues, for example, in the African region, say that in the last years, an impressive number of countries, I would not put the number here, but an impressive number of countries now have adolescent health focal point in the Ministry of Health. In past, just, a recent history was that the sexual reproductive health or maternal health focal point would also have the adolescent health agenda under their portfolio, with consequences that, adolescent mental health, for example, was overlooked, or adolescent nutrition. So now there is a progress, but we also need adolescent health focal points at district, and at least at district level as well. The reason is that when there is a person overseeing this, then things are more likely to happen. And it doesn't mean that, for example, adolescent health focal point or the programming at district level will be, you will have to have a network of parallel adolescent friendly facilities. No, this is not about it. This is about this person engaging in the discussion of strengthening primary health care. For example, the country is developing a new strategy for primary care, or quality improvement, or budget allocation. So that's the role of this person. And also the second role of this person is to capacitate district level managers. For example, if we are talking about district level, in what is different, what is about adolescent health and healthcare at district level that they should know and organize. So that's one thing. And this is, of course, not for the donors. But the second one is also for the donor community. Many countries now have national comprehensive adolescent health strategies and plans. Detailed plans sound. We were not out there to say this is your priority because we analyzed your estimates and we think for your nutrition is important. We never did it in any country, because actually the process of prioritization, it's many ingredients. It's evidence-based, it's the epidemiology, but also it's the feasibility and the perception of feasibility. So it's a combination. It's a objective and to some extent subjective process. But the confidence that you can do things is also important. So they have those plans, but those plans are not financed. And here is the tension between having promoting adolescent health as a program and promoting it as strengthening health system strengthening. It's not a completely opposite, but it's a slightly different approach. Promoting it as a program would mean, for example, national health focal point, district level focal points, local level focal points, and annual budgets for this program. And the annual budget for this program will then be disbursed to implement those plans. And then it will be up to the district level managers to prioritize how in this district to disburse this budget. And for example, the disbursement of the budget would be against district plans without imposing actions from the central level. The central level will provide capacity building wherever it is needed. Now, this is an impediment because those plans are not financed, And one might argue that it goes opposite for the concept of health system strengthening, because health system strengthening in an ideal world does not require additional budgets for adolescent health for the very reasons that I pointed earlier. You have the quality improvement mechanisms that operate, so you use those mechanisms to improve the quality for adolescents. But this is an ideal world, and in many countries, adolescent health programs are young programs. So we think until thinking adolescent health and well-being becomes a routine, becomes a default thinking for many decision makers, we do need this level of arrangement where the adolescent health program will have at least annual, biannual, or 5 years budget. So uh, I would encourage donors then to fund not separate activities, but to pull together funds. And for example, if several donors are working in Kenya with the adolescent health agenda, one from the HIV side, another one from school health side, the third one from nutrition side, pull together and fund those strategies and plans that were developed in collaboration with many sectors. It was a huge process, fruitful process, but it was fruitful up to a certain end. And now the implementation really, it's patchy. I'm not saying it's not happening. In Kenya, for example, district level AHA planning is happening. In DRC, so districts are now applying this process to prioritize the district level action. But that will be the second one. The third one is the tension between short-term agenda and the long-term agenda. So we all want quick results. When we report to donors, we need to show what impact. Everybody wants impact, that's another discussion. We want to work now with a global community of researchers to how to make a case. What is impact for longer term and complex intervention, but that's a separate discussion. So health system strengthening is a long-term agenda. So another plea then for the donors of whoever wants to invest, for the governments, do not invest in activities such as training providers from 5 facilities here and there. Instead, identify your key research academic institutions in the country and build the capacity, create national centers of excellence for adolescent health training. So those would be your existing institutions, medical training institutions, a couple, not everybody. In a country like Kenya, you have a lot. In a country like Ethiopia, there are a lot. Identify 1 or 2 who will lead the agenda, build the adolescent health academic and faculty staff type of leadership, and then they will train their peers and other institutions. It's a long-term agenda. We will not be able to report tomorrow to USAID that so many providers were trained in adolescent health care, but we probably will be able to report that in 5 years from now, Kenya institutions are producing medical cadres that already have the core competencies in adolescent health. And so in other areas, rather than investing in small projects, in local projects, or at least in combination, put some funding in strengthening the key institutions in the country in system strengthening. Over.
Thank you so much, Valentina, for the detailed explanation on these donor recommendations. I think, it's all very helpful, and I think you clearly answered that question. So we are running out of time. I know a few others have to drop off with remaining other calls, but I do want to say a big thank you to everyone that's joined this webinar and for the wonderful questions. And also want to take a moment to thank the World Health Organization and USAID's Momentum Country and Global Leadership for this collaboration. I really appreciate you all taking the time to clarify the processes to advance adolescent and youth health system strengthening. So before we wrap, I actually want to say a special thank you to our FB 2030 colleague, Kate Lane. She's led the adolescent and youth portfolio for many years, and this week is actually her last week at FB 2030. So we just want to applaud her leadership and hard work in this field. So thank you so much, Kate. And finally, we'll be able to share all of the resources shared from this from the chat and those shared by Valentina, Callie, and Kamani, the full presentation, and of course the recording. So please keep an eye out for an email from FV 2030. And in the meantime, you can reach out to us at info@fv2030.org with any additional questions. So thank you to everyone, and I hope you have a really great day. Goodbye.